information about restricting the amount of caffeine, as I see some of you with Monster energy drinks. So for all these caffeine contents, I've given you the serving size. The apple is on there for no reason. These are in chronological order in milligrams. It's just people say eat an apple every day, it wakes you up, but it has no caffeine in it. So 0 milligrams. 1 Hershey bar, 11 milligrams of caffeine. 1 12-ounce Diet Dew, 55 milligrams. 8 ounces of Ben & Jerry's Coffee Heath Bar Crunch. 84 milligrams of caffeine. 1 Foosh mint, which is like an energy mint, contains 100 milligrams in 1 mint. Monster energy drink, 160 milligrams. 1 12-ounce Starbucks brewed coffee, 195. 1 No Dose, 200 milligrams. Energy shot, 242. Rockstar, 250. So caffeine irritates the bladder. There are some medications that contain caffeine as well. Helping your patients look at medication labels is important. I had some clinical hours that I did with an industry nurse at Honda, and she said they had males that were coming in for Midol. And she couldn't figure it out, and she figured out they were coming in because they wanted the caffeine. So she said she couldn't figure out why males were coming in for PMS tablets, and that's why. Educating your patients about reading labels, that they do contain some caffeine. There are some medications that don't contain caffeine if you're giving your patients some suggestions for pain medications. Consuming a high amount of caffeine increases your risk for urinary tract infections, increases your risk for bladder irritation. Other things also do: citrus foods, alcohol, artificial sweeteners. So educating your patient about restricting and identifying sources of caffeine is important. As I talked about earlier, educating your patients about potassium sources to either increase, if you're at risk, but your patients with renal problems would have probably what level of potassium? High or low? High, correct. So probably the discussion with that renal patient will be more like restricting sources of potassium. So the serving size for these potassium sources are primarily 1 cup. And I recognize that it varies between brands and all that kind of stuff, but on average, these will just be, when you're looking at studying for that, just study the big ones. You don't have to study the 55 sources of potassium. And as I said earlier, banana will not be a choice for you, just because that was a 135 question in the year 265. Okay, so for all these different sources of potassium, which are good sources of potassium for your patient that needs it, they're also high in potassium for the patient to say, you know what, you need to stay away from these. 1 cup of cantaloupe, 407 milligrams. Orange juice, 496. A cup of yogurt has a lot of potassium in it as well. A banana. Yes.
Just one?
1 banana. That's a lot. So your patients are trying to restrict their potassium. Vegetable juice. A lot of potassium in that as well. Spinach. 839. Tomato sauce. A lot. Lima beans. 1 baked potato. A cup of raisins. So educating your patient to what are sources of high potassium is important. You don't have to know the recommended daily allowances within this course, but this is what it is, just so you know. Again, as I said, identify the items, the food items that have the biggest sources of potassium in them will be most important for you to know, which is the ones we just went over. Lots and lots of things fall into the category of high potassium. Educate your patient how they can Google that, look up some credible sources to figure that out, provide them with some printouts, and so forth. Sodium, as you know, our patient already has issues with high sodium, with water retention. So we definitely want to teach them about restricting their sodium. For your patients with renal, here are your serving sizes for these, which crack me up. 1 ounce of peanuts. And 2 slices of that. Then, how many make a sandwich with that beef with just using 2 slices? This is a TB dinner. Again, 1 ounce of cheesy puffs. Tablespoon of soy sauce. These are the serving sizes that we'll review. High sources of sodium for all of these. A tablespoon of ketchup. 1 ounce of peanuts. 1 ounce of cheesy puffs. Again, who eats 1 ounce at a time? I'm not sure. High sodium source there. 2 slices of that thin beef. 604. A half a cup of spaghetti sauce. 1 can of creamed corn as we head into Thanksgiving. This is 1/4 of 1 tombstone pizza. Wow. Yeah, there you go. A tablespoon of soy sauce. I don't know how you had Chinese for lunch. 1 can of chicken noodle soup. 1 TB dinner. So, educating your patients, these are sources of high sodium. We need to restrict your sodium, helping them read labels, teaching them that reduced sodium does not mean it's necessarily good, right? When you're in the store and you're like, there's 6,000 things to pick from. Reduced sodium just means that it's reduced by 25%. So if it has 1,000 milligrams of sodium in it to begin with, how many milligrams does it have in it if I could put reduced sodium on my label? It still has 750, a lot. So just because it says reduced sodium doesn't mean it's a good choice for you anyways. It only means it's only reduced by 25%. And I can still put that on my food label. So help educate your patient. No, this doesn't all mean the same. This. So teaching your patient the significance of that. Reading their food labels. Again, you don't have to know this part, but interesting. The recommendation is less than 2,400 milligrams a day, which equals 1 teaspoon of table salt. So those of you who eat popcorn and you have, all that kind of stuff. So how difficult it will be for your patient to start to limit their sodium when they're used to some of those sodium contents. These are all things that need sodium. Working with your patient, tell me what kind of foods you like. Let's go over a menu that you think would be doable for you. If you're going to tell them to eat this or not eat that, if you don't work with them and figure out what they like and what their preferences are, they're probably going to be compliant anyways. So what are some things we can start with? What kind of foods do you enjoy? Tell me what you normally eat through the week. Maybe we can help you figure out how we could swap some things out for something that's going to be less sodium. And it can't be all at once. So we whittle away a little bit at a time, see if there's a brand that works for you, all those kinds of things. Frozen dinners are usually huge with sodium content. Some of the ready-to-eat cereals are not great for that either. Vegetable juices, I think I'm drinking something healthy, and then look, I've got 653 milligrams of sodium in a cup. Canned vegetables are terrible. Deli meats, some soups, a lot of your condiments are pretty high, as you can see. A tablespoon of soy sauce equals 1,000 milligrams. There are some low salt, no salt versions of it. The problem is sometimes people buy them and then they take their table salt, and what do you do with that to make it more flavorful? There you go. Some of the spices have a lot. Peanuts, salty peanuts will not be a sodium choice for you in a couple weeks. Neither will salted pretzels. Prepackaged, a lot of those are high in sodium. Again, some of your condiments are pretty high in sodium. labels. Problems when you go out to eat, because sometimes, and oftentimes you can bring your own condiments. You know, if it's something that's lower in salt, you can go online and see what the sodium content is of some of the restaurant foods. So helping your patient figure that part out. Okay, here are some of the culprits from McDonald's. Even your grilled chicken, you think you're eating healthy, right? Yeah, not so much. One packet of that Newman's Italian dressing was 730 milligrams of sodium. Here's Burger King. You think you're eating a veggie burger, 1,100 milligrams. Yeah, why are we eating to walk around? Knowledge doesn't equate to compliance, remember? Here's Wendy's. Baconator, obviously, but here's your home style. I think you're doing good eating chicken and you're eating 1,100 milligrams of sodium. Here's Panera Bread. Sorry to burst your bubble. Yikes. Okay, I don't know what you all had for lunch, but now you're going to feel guilty about that. Thank you, Mom. I mean, you took you apple. Good job. Any questions on that? All right, we'll go over some NCLEX questions and then we'll finish the day out. Yes, there will be some dietary questions on there, primarily identifying potassium sources for your patient. Given a potassium level, what diuretic would you have him on, and what foods to either A, stay away from, or foods that he should increase. So if you know those primary potassium sources, you can answer that. Helping him understand what are some high sodium sources. That reduced sodium doesn't necessarily mean good for you sodium, right? Because that just means reduced by 25%. Sources of caffeine, that could include your medications. So read your medication labels, because sometimes they're sources of caffeine that you don't even realize.
Are you connected or no?
I'm afraid I am. You're stuck with me one more time. All right, we'll just do some review courses until 2 and then we'll take a break. What would you delegate? Delegate questions should be easy by now. Wouldn't have a thought about this one. Yep. Why can't you have me take your vital signs for you? Yes. Everybody clear and good with that? This is calculating a CBI. You won't have to do that for the sake of the test. The bag's going in, the urine out. We always subtract what we put in with the bag. You won't need to do that. So we have put those big monster bags in when we're irrigating for continuous bladder irrigation. You have to calculate the urine output, has to be the amount going in. Because the fluid going in, so you put 1,000 in, we'll say the patient's got 1,800 in his urinary bag. What's his true urine output? You put 1,000 in, he has 1,800 out in his bags. How much does he truly have in urine? 800. Does that make sense? You've got to calculate how much you put in over here. We had a patient this week that had a tumor removed, and the continuous bladder irrigation was to irrigate all the blood and blood clots and crap out.
Because I feel like most of the times that I've seen it, it's been for like patients that are bleeding. Like,
yes, because the whole irrigation is to irrigate all the blood out of the bladder for whatever reason that's in the bladder. Our patient had to get a tumor removed. No, they had it on Monday.
yeah.
Yeah. Okay. Thank you. Good question. Okay, what would you assign to an LPN? Can you assign assessing? No. Can you assign monitoring a patient? Monitoring. No slight to the LPNs, because I know you all do a lot, but stick with what you know about. Okay, so help me decide between 3 and 4.
Neoplastic, would that be cancer?
Correct. Anti-neoplastic needs chemo medications.
I would say 4.
And even if you didn't know that, what we just talked about, 4 is the least involved, right, out of all those options. So. This is a priority question. Okay, anybody else want anything besides four? Four is correct. Everybody good with that? Yeah, the ileal conduit surgery, he absolutely should be having urine. Anybody an answer on that one? Absolutely. If you picked increasing your vegetables as a priority, it's probably not the right answer. Anybody? Yeah, absolutely. The patient's having a significant complication.
Oh my gosh, I thought it said continue. Jesus Christ.
See, that's what happens on test questions sometimes. What did you say? Anybody have? Okay, why did you decide 3? Why did you rule out 1 and 2?
That was higher up, right?
And 1 and 2, yes, but 1 and 2, there's no fever, right? And we don't have any thought that there's any indications of an infection going on or inflammation.
There's no infection signs.
Correct.
So the bench trauma would explain that.
Correct, the blood in the urine. Correct. Anybody have a thought?
No kind of position. Because you're questioning why that catheter is being inserted.
And what else is significant about her history? Trauma, yeah. Which one of those lab findings is specific to a renal? Yes. So 1 and 3 are related to each other, which is actually sometimes the case when we have a patient that's got renal problems, right? But it's a renal disorder. We're not 100% sure whether it's a chronic issue that it would affect the erythropoietin or not. And so kind of like, I don't know about 1 and 3, but I know we talked about creatinine levels are specific to renal problems. So if you're kind of debating about all of that, what is specific to renal that maybe not wouldn't apply to anything else? Everybody okay with 1?
Yeah.
A week after, we don't have any indications really. We don't know about the kidney infection, but given the fact that it's a week afterwards, blood pressure's up, it doesn't fall in the criteria of chronic for sure. There's no indications he's got a kidney stone. What's the number 1 cause of urethritis in a male? STIs, STDs, whatever you want to call them. So which answer is probably going to be what you want to say? 4. Because urethritis in males, the primary culprit is sexually transmitted infections, and even if I didn't really know that, I would have picked the only answer that has anything to do with male parts, since you told me it was a male patient. So that might have been a good way to get to pick 4, even if you weren't 100% sure about the rest of it. You're looking for what? What's the question? Adverse effect. You're looking for something that's going on that's not going the direction you want it to go.
3.
Correct. Does that make sense? We want the creatinine level to go down, right? An adverse effect would be that BUN is not going down. That's going up. 4, that's pretty straightforward, yep. Anybody have questions about those, what we just covered? You feel clear about what is important to know? Anybody, anything? What other questions do you have? All right, we're gonna start the ATI at 2:15. So, I'm gonna get something to eat, stretch. And the ATI, just do your best on it, process the questions like you've been learning all semester. It'll be fine.